do people need to get to that minimum threshold, or do they need to exceed it? And, I think really it comes down to two things. One is, how much does an individual person need? And the second part is, how much did they start with? And, is it possible that those people who started out very, very low did need a high intensity intervention to get to that minimum threshold? And I think that comes back to another point that that many people, including yourself, Eva, have been making over the years, is that, exercise works. There might not necessarily be one that works better than others. And I think it comes back to, tailoring it to the individual needs of the patient. And so, of course, the important question there is, how do we identify what is best for the person that's sitting in front of us? But, there certainly is no one size fits all approach.
Dr. Snyder-Mackler would like to.
I have two things. One is, let's not generalize this all the way to PTOA and young people with a knee injury and what they have to do to be able, again, what kind of rehabilitation they should be doing. But also, Michael's, that particular paper that you brought up, realize that EMG activity is not percent muscle strength. So when we're talking about EMG activity, the amount of muscle strength that it takes to go foot over foot up and down stairs without significant superincumbent body movement is about 60%, which is pretty high for our OA population. It's not 20% of their muscle activity. So we need to really be able, you need to be able to think about EMG. It monotonically increases with muscle force, but it is not muscle force. So we need to be very careful about how we extrapolate that.
I think that's right, Lynn. I think we have idiopathic OA, which is what I deal with, and you've got PTOA, which is a totally different animal. So I think that's an excellent point on your part.